We'll now move into warnings and precautions. So, general, potential association with behavioral and emotional changes, including self-harm. So, pediatrics. So, placebo-controlled clinical trial data suggests. So, recent analysis of placebo-controlled clinical trial safety databases of SSRIs and other newer antidepressants suggest that use of these drugs in patients under the age of 18 may be associated with behavioral and emotional changes, including an increased risk of suicidal ideation and behavior over that of placebo. The small denominators in the clinical trial database, as well as the variability in placebo rates, preclude reliable conclusions on the relative safety profiles among these drugs. So, adults and pediatrics, additional data. There are clinical trials and post-marketing reports on SSRIs and other newer antidepressants in both pediatrics and adults of severe agitation-type adverse events coupled with self-harm and harm to others. The agitation-type events include akathisia, agitation, emotional lability, hostility, aggression, and depersonalization. In some cases, the events occurred within several weeks of starting treatment. Rigorous clinical monitoring for suicidal ideation or other indicators of potential suicidal behavior is advised in patients of all ages. This includes monitoring for agitation-type emotional and behavioral changes. The FDA meta-analysis of placebo-controlled clinical trials of antidepressant drugs in adult patients aged 18 to 24 years with psychiatric disorders showed an increased risk of suicidal behavior with antidepressants compared to placebo. So the general thing here is when you use an SSRI, there is an increased risk compared to placebo for behavioral changes, including suicidal behaviors. Discontinuation symptoms. So patients currently taking escitalopram should not be discontinued abruptly due to the risk of discontinuation syndrome. At the time that the medical decision is made to discontinue an SSRI or other newer antidepressant drug, a gradual reduction in the dose rather than an abrupt cessation is recommended. So escitalopram or Cipralex, treatment during pregnancy, effects on newborns. So in animal reproductive studies, escitalopram has been shown to have adverse effects on embryo or fetal and postnatal development when administered at doses greater than human therapeutic doses. There are no adequate and well-controlled studies in pregnant women. Therefore, escitalopram should be used during pregnancy only if the potential benefits to the patient justifies the potential risks to the fetus. Interference with cognitive and motor performance. So in a study with healthy volunteers, racemic citalopram, so again, this is Celexa, this is not Cipralex, but they're very similar, did not impair cognitive function or psychomotor performance. However, psychotropic medications that impair judgment, thinking, or motor skills, they may. Consequently, patients should be cautioned against driving a car or operating hazardous machinery until they are reasonably certain that escitalopram does not affect them adversely. Now, what about bone fracture risk? So, epidemiological studies have shown an increased risk of bone fractures following exposure to some antidepressants, including SSRIs and SNRIs. The risks appear to be greater at the initial stages of treatment, but significant increased risks were also observed at later stages of treatment. The possibility of fracture should be considered in the care of patients treated with escitalopram. Elderly patients and patients with important risk factors for bone fractures should be advised of possible adverse events which increase the risk of falls, such as dizziness and orthostatic hypotension. Orthostatic hypotension would be a sudden drop in blood pressure when going from a seated to a standing position. especially at the early stages of treatment, but also soon after withdrawal. So for the precautions, I don't think it will be helpful to go through each precaution, but we'll go through the list, and any ones that jump out, we'll take a read through them. So patients with cardiac disease, so neither escitalopram nor citalopram has been systematically evaluated in patients with a history of myocardial infarction or heart attack or unstable heart disease. Patients with these diagnoses were generally excluded from clinical trials during the drug's pre-marketing assessment. So in line with other SSRIs, including citalopram, escitalopram causes statistically significant but clinically unimportant decrease in heart rate. So in patients less than 60 years old, the mean decrease with escitalopram was approximately 2.3 beats per minute, while in patients greater than 60 years old, the mean decrease was approximately 0.6 beats per minute. Consequently, caution should be observed when escitalopram is initiated in patients with pre-existing slow heart rate. We'll skip over QT interval prolongation. Let's see what they have to say about diabetic patients. Neither escitalopram nor citalopram, so they haven't been evaluated either. Rare events of hypoglycemia were reported with citalopram. Treatment with an SSRI in patients with diabetes may alter glycemic control. So hypoglycemia and hyperglycemia, high blood sugar and low blood sugar. Citalopram should be used with caution in diabetic patients on insulin or hypoglycemic drugs. In terms of abnormal bleeding, so SSRIs and SNRIs, including escitalopram, may increase the risk of bleeding events by causing abnormal platelet aggregation. Concomitant use of ASA or non-steroidal anti-inflammatory drugs such as Advil or warfarin and other anticoagulants may add to the risk. So case reports and epidemiological studies have demonstrated an association between the use of drugs that interfere with serotonin reuptake and the occurrence of gastrointestinal bleeding. So bleeding events related to SSRIs and SNRIs use have ranged many different things, all the way up to life-threatening hemorrhages, down to just small bleeds. So patients should be cautioned about the risk of bleeding associated with the concomitant use of escitalopram and NSAIDs or ASA or other anticoagulant medications. Let's see what they have to say about hepatic or liver impairment. So based on a study conducted with escitalopram in patients with mild to moderate hepatic impairment, the half-life was approximately doubled and the exposure was increased by approximately 2/3 compared to subjects with normal liver function. Consequently, the use of escitalopram in hepatically impaired patients should be approached with caution and at a lower dose. So no information is available about the pharmacokinetics of escitalopram in patients with severe hepatic impairment. Escitalopram should be used with additional caution in patients with severe hepatic impairment. We'll skip over seizures, and neuroleptic malignant syndrome, and serotonin syndrome. Glaucoma, as with other SSRIs and SNRIs, escitalopram can cause mydriasis and should be used with caution in patients with raised intraocular pressure or those with narrow angle glaucoma. Okay, so this is an important point here. So suicide/suicidal thoughts and clinical worsening. So depression is associated with an increased risk of suicidal thoughts, self-harm, and suicide, or suicide-related events. This risk persists until significant remission occurs. As improvement may not occur during the first few weeks or more of treatment, patients should be closely monitored until such improvement occurs. It is general clinical experience that the risk of suicide may increase in the early stages of recovery. Therefore, high-risk patients should be closely supervised throughout therapy with consideration to the possible need for hospitalization. In order to minimize the opportunity for overdosage, prescription of for escitalopram should be written for the smallest quantity of drug consistent with good patient management. Other psychiatric conditions for which escitalopram is prescribed can also be associated with an increased risk of suicide-related events. In addition, these conditions may be comorbid with major depressive disorder. The same precautions observed when treating patients with major depressive disorder should therefore be observed when treating patients with other psychiatric conditions. So this one, personally, I find, as a patient who has bipolar himself, I find this one personally interesting. So I'll read through this one. Activation of mania and hypomania. So in placebo-controlled trials of escitalopram, activation of hypomania, or mania, was reported in one patient of 715 treated with escitalopram, and in none of the 592 patients treated with placebo. Activation of mania or hypomania has also been reported in a small proportion of patients treated with citalopram and with other marketed antidepressants. As with other antidepressants, escitalopram should be used with caution in patients with a history of mania or hypomania. A major depressive episode may be the initial presentation of bipolar disorder. Patients with bipolar disorder may be at an increased risk of experiencing manic episodes when treated with antidepressants alone. Therefore, the decision to initiate symptomatic treatment of depression should only be made after patients have been adequately assessed to determine if they are at risk for bipolar disorder. Now, speaking about the kidneys, so hyponatremia or low sodium, as with other antidepressants, cases of hyponatremia or SIDA, syndrome of inappropriate antidiuretic hormone secretion, have been reported with escitalopram and racemic citalopram as a rare adverse event. So again, a rare adverse event. The majority of these occurrences have been in elderly individuals, some in patients taking diuretics or who were otherwise volume depleted. Elderly female patients in particular seem to be a group at risk. Caution should be exercised in patients at risk, such as elderly or patients with cirrhosis, or if used in combination with other medications which may cause hyponatremia, low sodium. What about renal or kidney impairment? So no information is available on the pharmacokinetics or pharmacodynamic effects of escitalopram on patients with renal impairment. Based on information available for citalopram, no dosage adjustment is needed in patients with mild to moderate renal impairment. Since no information is available on pharmacokinetics or pharmacodynamic effects of either citalopram or escitalopram in patients with severely reduced renal function, escitalopram should be used with caution in these patients. What about nursing women? So studies with escitalopram have not been performed in nursing mothers, but it is known that citalopram is excreted in human breast milk. And it is expected that escitalopram is also excreted in breast milk. Escitalopram should not be administered to nursing mothers unless the expected benefit to the patient outweigh the possible risk to the child, in which case the infant should be closely monitored.